TopMedTalk. Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress at Euro Anesthesia 2019 in Vienna, and I'm here with Editor-in-Chief Monty Mythen. Hello, Monty. How are you, sir?
Hey, good. I'm good, Desiree.
And so we actually have our special guest with us this morning, Michelle Chu. Good morning, Michelle. How are you?
Good morning. I'm very good. Thank you so much for asking me to come.
I know. I was really excited when I met you yesterday. I'm like, oh, we're going to have such a great conversation. It's going to be good. So, Michelle, tell us, where are you from?
Well, I'm Australian, but I've worked in Sweden for the last 15 years, so I'm definitely not Swedish, but this is, it's my new adopted country.
So where are you working now?
So I'm working at Linköping University Hospital. It's a major center in Sweden. There are 8 major centers, universities, of course. And it's probably a large hospital for Sweden, but probably not in terms of world standards. 700 beds. We've got 3 ICUs, a general ICU, a burns ICU, and thoracic ICU. No NICU or PICU. And we only have 8 beds in our general ICU, which is a very low number. This is normal for
700,
Sweden.
700.
Yes.
Yeah. Wow.
Yeah.
Holy cow.
And
do you have a lot of intermediate units though?
We do have intermediate units. Sweden is well known for having a very low number of ICU beds.
But good outcomes.
Reasonably good outcomes, yeah. Yes.
Oh. So is there a message there?
Well, I'm sticking my chin out. I think the message is excellent teamwork, and the Scandinavian countries are very good at it. They're very good at getting the whole team behind the patient. It's very much about the team and not the individual. And certainly that would be a feature of perioperative care. Nurse anaesthetists are central to anaesthesia. And in fact, I would say the majority of anaesthetics are carried out by nurse anaesthetists under the supervision of an anaesthetist, of course. Yeah.
Really? I did not realize there was a large presence there. Are there opportunities for nurse anesthetists to practice independently at all, like in rural settings or anything like that?
No.
It's always under supervision.
That's right.
Huh. That's really interesting.
And the major surgical patient who may need a higher care environment, is the ward a higher care environment than many places? With only 8 ICU beds, they've got to go somewhere, haven't they, to get through the cases?
Well, we have postoperative care units that can admit patients for up to 24 hours. Okay. And then, by definition, after 24 hours, they become an ICU patient.
Yes.
Now, where the patients are physically differs from hospital to hospital. So you would have units, say, like at the Karolinska, that have the possibility to have patients for, up to 72 hours.
They had more than 8 beds.
They have more than 8 beds. But, to be interesting...
I've visited there recently. They definitely have more than 8.
But not that much more. I think they have something like 10 or 12 beds in their ICU.
Right.
And then they have their the postoperative care unit that has... I think they have something like 30 beds.
Yeah, but if you go into it, it looks like a bit like ICU.
Right.
Yeah. It's got a high-end monitor. It's got a lot more nurses around. You can monitor and give vasoactive agents.
Absolutely. And in that way, the definition of ICU is probably a little bit different in Sweden, because in most PACUs, certainly in all the university centres, you'd be able to provide single organ support.
Yes. Yeah. So, Michelle, what is your role there?
Well, I have a dual role. So I'm officially employed by the university, and I'm the chair of anesthesia, intensive care, and acute medicine.
Oh, okay.
Right. And then I have a 1/3 clinical loading, which I really like, and which I feel is really important. If you're going to do clinical research, you've got to be on the floor.
Yeah. So, Michelle, our guest that was just here, he attended your pre-Congress workshop.
Oh,
can you tell us a little bit about what the pre-Congress workshop was about?
Okay, so it's a pre-Congress. It's a one-day pre-Congress course, and it's run by Bernard Walder and Bernardo Bondan-Pinto from Geneva, and they're an extremely experienced team, very much interested in perioperative education. And the agenda there really is to raise awareness that, perioperative care doesn't stop in the OT, it doesn't stop in the PACU, but, it's a continuum. And one of the things that we were saying during the course is, why do patients undergo surgery? When we talk to our patients, they don't say, I don't want to die. They say that I want to get better.
Yes.
I want to have a health, a quality of health or a level of health that is at least as good as what I have now, and preferably even better.
Yeah.
And they certainly want to survive for longer than just a perioperative period, what we normally consider the normal perioperative period.
Well, we said this last night. You were telling me this story, and you said they don't say, I just want to live. They say, I want to, dance at my daughter's wedding.
Right.
Right. I want to run. I want to be able to run again, or, whatever that is.
Right.
And to talk about that, when you go in and that consent form is a contract to get better.
Indeed.
Isn't it? To improve.
Yes.
It's not a contract to get worse.
Yes. And that's interesting. What you've hit the nail on the head, Monty, because, if you look at all the major trials, we measure outcomes in the negative. We measure mortality. We measure morbidity. But what's important to patients is the gain.
Yes.
Yeah. Is the gain in healthcare.
Did I get what I wanted out of this, what I wanted the knee surgery for? We reflected a number of times on TopMedTalk, and when we look at our data from the UK, patient-reported outcomes, the knee almost always gets better.
Right.
But the life doesn't always get
quality,
better. Sometimes the life gets worse. And that's the discussion we need to have. May I, Desiree, I want to take you to acute kidney injury. Because we've always been interested in organ dysfunction, but acute kidney injury is a hot topic at the moment. And you've written quite a lot about this, that there's now a greater recognition that a little creatinine bump is not a benign thing.
Right.
And that some of the AKI transitions into chronic kidney disease. Could you tell us a bit more about that?
Yes, I think there's quite a lot of data out there now showing that, it's not just with AKI, with everything, troponins, small blood pressure drops, small heart rate rises, the small changes do make a difference. And in that, I think it was Claudia, a species group, it was Felix Cork, I'm pretty sure, that did that. It was a large, although retrospective but cohort study showing that just a tiny drop in creatinine, something that I wouldn't react to, a 25% drop actually is very strongly associated with poor outcomes. Yes. And interestingly, in that same study, they showed that if you were a cardiothoracic patient for the same level of creatinine rise, you would have much better outcomes. So that makes me wonder, what are the cardiothoracic anaesthetists and surgeons doing differently? Is it because they're more vigilant? Are they preventing failure to rescue?
Well, it varies enormously, I think. We've been talking about this, that some centres in the USA, one in particular, is reporting that they seem to have almost eliminated acute kidney injury.
Oh, really?
Yes, by a very, very proactive. Well, they have the luxury of all patients going to a critical care environment. Two is they almost universally have hemodynamic monitoring with all the different platforms available and echo. And now they've been using these kidney stress markers.
Yeah, the biomarkers.
Nephrocheck, for example. And getting onto the patient quickly if there's a hint of renal pain. And maybe it's the same thing with troponins and myocardial injury.
Yeah, I guess the evidence for using individual triggers or whatever is not quite there yet, but perhaps the lesson that we can learn from that is being on top of things, preventing things from getting too bad without noticing it, and coming after the fact.
Yeah. So how you talked about your workshop, and we're talking about these, post-op AKI, and all these are in your workshop. How did you talk to the group about getting into the post-operative space? Because again, we had this conversation last night that I think anesthesiologists do a really good job about the pre-op piece, but you said extending it out. And we know that as we talk to people, people just don't know their rates of AKI and things like that. So were you addressing that?
Yeah, the question that I asked the question that I asked the audience, and you were into this, Monty, because I remember you giving I think we had a workshop together at the Geneva conference. Yeah. You know, you could ask any anaesthetist and they would be able to tell you how many patients suffered a major event or died on the table. They'd be able to tell you that in the last year. They might be able to tell you how many patients had a major adverse event in the PACU or had died in the PACU. They might be able to tell you that. And then you go in and ask them, how many of these patients died in hospital?
They don't know.
They don't know. How many died within 30 days?
Most don't know.
Most don't know. Right, unless you're regularly auditing your numbers. Within 30 days, within 1 year, within 5 years, most anaesthetists, and even surgeons for that matter, don't know that.
Yeah. I just find that fascinating because, we're trying to move the needle on that, and it's really difficult when people just don't understand what their outcomes are.
So at Anaestheisa 2019, last month in London, we had a panel which included a senior representative from NHS England, who is a surgeon, female surgeon, Celia Ingham Clark, who talked about the new vision for the long-term scorecard. It's not there yet, but it's just describing a vision whereby you'd know the whole of the patient's surgical journey, from when they had their surgery, what went into them, what was taken out of them, and the team players would be listed on the card, if you see what I mean, that would then stay with them. And a year later, you'd know the outcomes, because it wouldn't just be the surgeon. You'd list the anaesthetist, you'd list the nurse that was involved, you'd list the pharmacist involved, such that if there was a mistake with a drug and they got acute kidney injury, they could reflect on that it might be related to it. I think that's a brilliant idea.
Yes.
So I was just talking to, I think it was Dave O'Connor from MSK, Memorial Sloan Kettering, and saying that they have a dashboard that's been created that's showing them postoperatively if their patients are coming up and they're getting pinged for, not dinged, but they're getting, they're letting them know if they have a patient with a post-op complication.
Bring it on.
Absolutely. We need to know,
Yeah, we need to know. If nothing else, just as a reflection, as some sort of reflection on the work that you've done, because we all do our best.
Yeah.
We all do what we think is best for the patient. And if we don't measure, the outcomes at an appropriate time point, then you can't really make that judgment. And in that way, I think the NHS is doing an amazing job. It's the only country. Well, the NSQIP has a similar kind of program, but I think the NHS is very much more inclusive with the whole perioperative group. And we don't have that in Scandinavia, and perhaps you should come and talk to
no one listens to me.
They don't listen to me either.
Oh, yeah, right.
We'll send Desiree.
That'll work.
Yeah. Oh, gosh, that'd be fun. Well, Michelle, I know that another topic that you're really interested in is the MINS story. So can you tell us a little bit about what you've been doing with that? And
MINS, again, we should remind
yes,
people.
Sorry, I know, we talk about it all the time.
Myocardial injury after non-cardiac surgery, is that right?
Right, that's right.
So a troponin rise, the blood test rise, without any other overt signs that someone's having a heart attack.
That's right, and what you've said is exactly correct. It's the rise in troponin, and I might be sticking my chin out again because and I'll tell you why in a minute. I believe that you need to measure the rise, the change in the levels.
Delta means.
Yeah, the delta.
Troponin.
Yeah.
From pre-op?
From pre-op.
Okay.
Yeah. Now, the reason for, the vision study, the first vision study only measured post-op troponins. The second vision study had a proportion of patients that measured pre-op troponin. But the whole reason why we're interested in means, we're interested in the heart in any high-risk patient. So that's both critical care and perioperative care. But if you look at the numbers, we have 800,000 procedures in Sweden every year. A substantial number of those patients will go on to develop complications. The most common complications are still cardiovascular. Cardiovascular-related, bleeding-related, respiratory-related. Right? Now, if you look at cardiovascular complications, a lot of those patients will have poor outcomes. If they don't die, they have a poor quality of life. They have, they don't get back to the level that they were at pre-surgery. So that's a concern for me. Otherwise, why go through surgery if if you're going to end up in a worse position than you were prior to surgery? So that was the whole impetus behind it. And then when the vision study came out, I nearly fell off my chair because it was like 8%. This is with the old asset, 8% of all patients, and with the new vision study, 18%.
Yeah.
Right, 18% of all patients that, in that cohort suffering from a myocardial injury. And then you could argue, okay, it's just myocardial injury, it's a rise in troponin, and so what? Well, it turns out that even after extensive adjustment, it was strongly associated with 30-day mortality. Right, so this rise in troponin that the patients don't feel because 93% were completely asymptomatic.
Yeah.
Right? So you don't know it exists until you actively go out and look for it. It's a bit like the creatinine story.
So I just challenge you a little bit there, Michelle, because my MINS enthusiastic colleagues tell me that these are patients who are sitting there overtly completely well, no problems at all, eating breakfast, looking fantastic, and they just got a big troponin rise, and that predicts badness. I've just never seen it. I see it in patients who look sick to me, but not in patients who apparently look very well.
Yeah.
So I've got a disconnect there.
Yeah.
So, I can see where people are coming from. I get it. I've seen the things, but when I see the ones with troponin rises, they always look sick to me, not well. They're not having heart attacks, if you see what I mean, but they've got other stuff going on.
Yeah. Well, I guess the people who look sick are sick, right?
Yeah.
And the people who don't look sick,
Yeah.
If you look at all the available studies, they still tell you that the people who don't look sick
are the big risk.
Are the big risk. The problem is we don't know what makes them, why they die. That's the thing. There is no causal.
Well, that's what I was going to ask. So, I mean, you have, it increases 30-day mortality and all that, but, true outcomes, you don't really know exactly what
why?
is the problem.
Are they having a coronary event, or is it just a supply-demand problem that's masked by, a thoracic epidural or opioids or whatever it is? We know that an increase in troponin, whether or not it's an absolute increase postoperatively or a relative, a delta troponin, is associated with badness. Yeah. For want of a better word. But why? We still don't know. And there are a few studies going on. And there's one current study ongoing in Sweden that is taking patients with increased troponin levels into the cath lab postoperatively to see if it is a coronary event.
Yeah.
And any heads up on that yet? Or?
No, you'll have to ask. You'll have to ask Anil about that.
That's really funny. Well, Michelle, thank you for sitting down with us. We'll have to wrap it up here and get going. I know you have a busy schedule, but we really appreciate you sitting down.
And we're doing a lunchtime session together later.
Yeah, that's right. I was
just
going to say that Edward's Lifetime Lunch Symposium you guys are going to read too, so I can't wait to see that and hear more about it. But so you have do you have any new research or anything coming out?
Well, we have the MINS study, the myocardial injury in noncardiac surgery in Sweden. So it's MINS. But it turns out it's also in Switzerland.
Oh. It's got 3 S's on the end.
That's right. So we're still recruiting. We should be finished recruiting by November.
Okay.
So that's probably the largest biomarker study looking at the value of adding a biomarker to preoperative risk scores to improve the classification of risk.
Oh, okay, cool.
And will you do something different about the identified risk patient, or is that further down the line?
Yeah, so that'll be the next study. If we do see that we can improve the classification, then we would have to organise some sort of an interventional study based on that classification.
Major surgical patients or
major surgery? Okay. Yeah.
Because vision included quite a lot of day case surgery, which is the
exactly, and we've taken out the day case.
Yeah. All right. Well, we look forward to hearing more about that in the coming year. So, again, thanks for sitting down.
Thank you so very much for having me. It's been
great
fun.
to see you. Thanks.
Cheers. All right. Thanks.
TopMedTalk. Nick Majerison here. Have you got yourself onto edpom.org yet? If not, you might not be aware, EdPom Chicago tickets are free for a limited period only. Go now to edpom.org. Evidence-based perioperative medicine. edpom.org.